Hi, good afternoon, everybody. My name is Sadaf. I'm part of the NeoFOCUS education group. I'm a consultant at UCLH in Great Ormond Street, and I'm really pleased to welcome today for our NeoFOCUS webinar Professor Danielle De Luca, professor in Paris, be introduced shortly by Dr. Banerjee, who's a consultant neonatologist at Queen Charlotte's Hospital in London. I also have the pleasure to welcome Dr. Banerjee, but also Dr. Harsha Gowda, consultant neonatologist at Birmingham Heartland Hospital, and Dr. Mahmoud Montasser, part of NeoFOCUS group, who is a consultant neonatologist at Wishaw Hospital. I'm going to hand over to you, Jay, to continue. Thank you.
Thank you, Sadaf. I hope you can hear me. So Professor De Luca doesn't need a huge introduction. I'm sure you all seen how much his contribution is towards in this field. So as you're all aware, he's from Paris-Saclay University, from Paris, and he has specially come all the way from Paris. He was no, not really, but he has come to London. So we thought it would be a perfect opportunity to learn about what's happening in the field of lung ultrasound in relation to RDS and chronic lung disease, and what the future holds for us. So take it away, Dr.
Thank you, Jay, and thank you everyone for the kind introduction and the presentation. It's right, I'm not here for that, but I'm very, very happy to contribute and to come over anytime or to work with you. It's a real pleasure. Moreover, Simon, Mohammed, and other friends over here. So I'm really, really happy. And the title of my presentation, you asked me, it's a little bit intriguing because I'm going to speak about RDS and bronchopulmonary dysplasia, so the two main topics, although there are many others for the use of lung ultrasound in neonatology, but also with a little bit of clue about the possible future development and what the future is holding up for us. So to me, if you look at the list of the many different things that you can do with lung ultrasound, RDS and BPD are here. They both belong more or less on the functional application of the lung ultrasound. It's just looking at the lung, but it's also eventually assessing how things are going and what we can do in terms of therapies, prediction, and support on a daily basis for these babies. So those are the two things that we'll be talking about. But again, as you can see, the list is much longer, and you can do many, many other things with lung ultrasound. And obviously, I could speak about that for like 3 days, which I'm not doing today. It's just for another time. So the first leg of the presentation will be about obviously the ultrasound management of the RDS. And you all know that lung ultrasound semiology is very easy. It's just based on 4 parenchymal signs that you can see here, from the left to the right side, from the fully aerated to the completely lost aeration of the lung. So that means that these 4 signs are representing a sort of an ordinal variable, as we say in statistics, meaning that this one, the very last one, is right here and cannot be placed like here or the other way around, because there is an order between them. And on this order, every type of lung ultrasound score is based. Now, I can anticipate to you, although it's at the end of the presentation, that there is a European consensus between adults and pediatric and neonatal intensivists going on, and we will be shortly required to call them lung ultrasound aeration score, to be absolutely precise, and that's the way I will call it during my presentation. Now, you can calculate a lung ultrasound aeration score with almost any probe. That's good news. But for the sake of my presentation and for precision reasons so far, we have been using mainly this one, the OK stick microlinear probe, which is around 15, 18 megahertz, more or less. So everything I'm referring will be referred to that probe. And that's important because you'll see by the end of the presentation that things can go a little bit differently if you use other probes, although their use is absolutely possible. So the history started in 2014 when we decided to modify the lung aeration ultrasound score used in adult ICU for babies, right? And to do that, obviously we couldn't change the semiology because semiology is the same across the patient's ages, so the 4 signs that are scored from 0 to 3, but we decided instead to change let's say the boundaries of the chest zones that are supposed to be scanned with the ultrasound. So you see since the baby's chest is smaller than the adult chest, we only limit the scan to the upper anterior, lower anterior, and lateral zone. So this makes 6 chest areas for every single baby. So you do your math. The signs, they go from 0 to 3. So you do your math, and your score can go from 0 to 18. Very easy. And the higher the score, the lower the lung aeration, the thicker will be the lung, right? Now, that's for the pure calculation of the lung aeration score. Now, before applying it to the clinical practice, we wanted to be extra sure about what we were actually doing. So first of all, we try to validate it with the activity of surfactant that has been extracted from the amniotic fluid at the delivery in preterm babies. So this graph that you see on the right side is coming from my lab in Paris, and it's about 51 babies below 32 weeks. And you see on the y-axis, we measure the surfactant activity in terms of surfactant absorption, so in terms of ability to float at the air-liquid interface, like surfactant is supposed to do in our alveoli, and you can clearly see the relationship with the lung ultrasound score. So again, the higher the score, the worse the surfactant activity. For a particular population like the preterm babies, where RDS, meaning hyaline membrane disease or surfactant deficiency, whatever you may want to call it, that, which is obviously very frequent in that particular population, that means that the higher the score, the more RDS you left somehow, right? So that was the first sort of a validation. Now, if there is a correlation between the amount or the activity of surfactant and the lung ultrasound, that also means that you should find a correlation between surfactant and compliance or the stiffness of the lung. And this is what we did together with another ICU, an adult ICU, and we were particularly interested in seeing the correlation between the lung ultrasound aeration score and the compliance. So you see here, on the top, you see the adults, and on the bottom, you see the babies. Nothing changes across the patient age. So the higher the score, the lower the compliance. And if you divide the patients, it's always the same. Here you see, for example, those were adults with ARDS, mainly due to COVID. Those were newborn babies with ARDS due to meconium aspiration or infections or anything else, very high score. Preterm babies with RDS without the A are over here, slightly lower score, but still quite high compared to controls like babies or adults and intubated for neurological reasons and so on. And obviously, the compliance here has eventually the specular appearance, so confirming what I just told you. Another step forward, if there is not enough surfactant, and this is correlated to the lung ultrasound score, and this makes an increment in, a decrease in compliance, this eventually means that you're going to get worse oxygenation when you have higher lung ultrasound aeration score. And this was exactly what was happening. You see here, there's a strict correlation between the lung ultrasound score and any type of oxygenation metrics like the oxygenation index, the PF ratio, the gradient, and so on and so forth. So the message is always the same. The higher the lung ultrasound aeration score, the worse the respiratory function at the end of the day. So if we put all this information in terms of pathophysiological cascades in a preterm baby, for example, with RDS, you see here, you don't have enough surfactant pool, which means not enough surfactant function as we measure it. And then this brings us to impaired lung mechanics, so lower compliance, increased elastance. And then this, in its turn, implies a reduced lung aeration, so less air into the alveoli that are stiffer and smaller because of the previous steps. And at the very end of the cascade, you get worse oxygenation. So that's a cascade, right? And with the lung ultrasound, you can have a look here at that level, while when you only look at the FiO2 or anyway, even a more complex oxygenation metrics, you just look at the bottom of the cascade. So you are, let's say, looking a little bit higher. Obviously, as you can see here, there are many other tests and techniques that can be used to, analyze all these steps. But most of them are not available at the bedside, and or they are too cumbersome or invasive, or for other reasons that are not available. Now, we validated the lung ultrasound aeration score in newborn babies with these ways, with these techniques, just because we couldn't use the real gold standard, which is indeed the CT scan. But in adults, the lung aeration ultrasound score has been validated against a number of techniques, as you may see here, some of them very invasive, but the most important thing, again, is the CT scan. So I just wanted to show one study, the one published in Critical Care Medicine in 2018, where you can clearly see here that's an interstitial lung and a clear interstitial pattern at the ultrasound. And here you can clearly see the relationship between the lung ultrasound aeration score and the lung intensity at the CT scan. It's really, really strict. We can do that for above radiation exposure reason in the newborn babies, but we have no reason to think that physiology would be any different compared to adult patient. And now, to give the credits to those that actually did that for the first time, back in those days, in 2007, 2008, Roberto Copetti from Northern Italy described for the first time RDS, meaning hyaline membrane disease, with the ultrasound. And you see here, RDS, as we all know, it's a uniform white lung everywhere without any spared areas. You get some pleural line irregularities with some subpleural small consolidation, and now we know are supposed to be less than 1 centimeter in depth and or less than 0.5 centimeter per kilo, because above the baby can go from 400 grams to 4 kilos. But anyway, that's the appearance. And remember how uniform is it, because this has come handy by the rest of my presentation. Now, it's important to understand that what Roberto Copetti described is nothing more than the ultrasound counter site of what has been described for the first time back in the 60s by Mary Ellen Avery and a group at the time. You see, those were the lungs of newborn lambs, preterm newborn lambs, delivered at 128 days of gestation, which accounts for more or less 28, 29 weeks of human gestation. And they measured the surfactant phospholipids in every single, lung lobe. And they obviously found that surfactant was not enough. It was very, very low in every single lobe. And in fact, you see the picture, both lungs were absolutely congested. That means that when you really have RDS, you just can't have RDS on the right side and not having RDS on the left side or vice versa. If you have RDS, you have RDS. And this is exactly why we have seen everything so uniform, let's say a generalized white lung. Now, we did this study over more than 2 years. That has been very, very hard to be done, where we analyzed the heterogeneity of different lung diseases when you use lung ultrasound. And no surprise at all, RDS, both in terms of intrapatient and interpatient heterogeneity, is the disease with the lowest heterogeneity compared to TTN, BPD, and even ARDS, although ARDS is a little bit of everything because you get meconium, you get blood aspiration, you get sepsis, you get pulmonary hemorrhage. So that's another chapter for another talk. But anyway, RDS is homogeneous. And in fact, it's homogeneous with the preponderance of white lung and a little bit of interstitial edema as well. Now, if it's really homogeneous, according to the science, according to the lung ultrasound semiology, you get the white lung almost everywhere. And since the white lung is supposed to be coded to be scored 2, you should get a lung ultrasound aeration score of more or less 11 or 12. You do your math, and that's what you get. And in fact, you see here, you have a lung ultrasound score more or less of 11 here upon NICU admission. That's after 6 hours, 12 hours, 24 hours, and 72 hours after birth. It's interesting to see that those are the RDS babies, and those are the TTM babies. Though there's no intersection, you can clearly recognize them at any time point during the trip, right? It's always different. It's also interesting to see that if you look at the oxygenation index, so that's the oxygen saturation index, you see the shape is very much the same. It's very much the same compared to the lung ultrasound score. So you can recognize TTM from RDS at any time point. And I'm sorry, yeah. Now, a little bit of criticism against the European guidelines that were up to a couple of years ago, only looking at the FiO2. So I'm sorry, but physiology is complex, and I love this point. Imagine two babies. Like the first one has 40% of oxygen, a good saturation 95%, and CO2 is 50, right? And this is for both babies, right? Now, are they actually equal? We cannot know that just from these numbers, right? If I add a little bit more, I can tell you that one baby has just 6 centimeters of water of pee pressure, and PaO2 is 45, and the other one is 18 centimeters of water of pee pressure, and the poor guy has 35 millimeters of mercury of PaO2. Clearly, we are talking about two completely different babies, and in fact, one is on CPAP and the other one is on ECMO. That's just a joke, but it's just to tell you that things can go very, very differently, and it's not just about the FiO2. But even if we look at that type of baby here, so forget about ECMO, let's do another example, only on that type of baby. So here on the left, you have Tommy, and on the right side, you have Laura. It's funny because one of my fellow name is Laura, and actually fiance is actually Tommy. But when I invented this slide, I didn't think about them, and then I discovered this. But anyway, Tommy and Laura. Now, Tommy has 30% of oxygen and 7 centimeters of water of CPAP, and Laura has 45% of oxygen and 5 centimeters of water of CPAP. Who's the sickest? What do you think? Between Tommy and Laura, who's the sickest one? Tommy is sickest. Yeah, it depends on how you see things. Actually, I don't know. That's my answer. Because if you look at the FiO2, you may, reply in a certain way. If you look at the CPAP, you may reply on the other way. This one is pronated. The other one is supine. That can have an impact, for example. But then if you calculate all the bloody, oxygenation metrics, as you can see here, like the gradient, the oxygenation index, the SF ratio, and many others, it's a mess. For some of them, Tommy is sicker than Laura. For some other, it's the opposite. Some are absolutely the same, like the oxygen saturation index. It's complicated. And that's just because oxygenation is a complicated process from a physiological point of view. And FiO2 is one of the many factors that are impacting on oxygenation. But looking only at the FiO2 is like, looking at that room through the hole, you don't know exactly what is happening into the room. Besides that, we have temperature. We have patients who have an unpredictable amount of fetal hemoglobin, because we are the only doctors taking care of patients with fetal and adult hemoglobin at the time, and that's already very much complicated. And then you have the difference in PEEP pressure and in pressure leaks. For example, here you see we had a little bit of a fun measuring the pharyngeal pressure and so calculating the leaks, and I can tell you that you get like 50% here, around 30%, irrespective of the type of non-invasive respiratory support techniques that you use, and this should be taken into account. None of us use chin straps for these babies, I guess, so leaks are there and are not measured anyway. Despite we all got pressure leaks, the different level of CPAP applied to these babies makes a difference sometimes. That's a study that we just finished it, and you see babies have been shifted from 4 to 6 and then to 8 centimeters of water of CPAP. On the left side, you see the RDS babies, and here on the right side, you see the TTM babies. Now, remember, white lung, interstitial pattern like discrete B lines, and A lines, so normal zones. When it comes to babies with RDS, the increment of CPAP from 4 to 8 doesn't change very much. You see the white lung goes down from almost 80% of the chest zones to 71. Yes, a little bit, but not so much. And in fact, you see the A spared areas, the normal areas are more or less the same. When it comes to TTM babies, conversely, you get some difference because the white lung and the interstitial lung are being reduced, and the A zones are more frequent anyway with the increment in CPAP. And basically, this is what you see. Those are the RDS babies, and those are the TTM babies. So it means that when the alveoli are really, really stiff and they're really, really small, if you increase a little bit the PEEP, you're not going to get anywhere. Conversely, if it's just a problem of water, because you have too much fluid in the lung, you can push the water out of the lung by increasing the PEEP, and you can eventually see the difference. We calculated all the differences, and you can see here it's going to be statistically different from the lung aeration score point of view, but those are very, very small absolute differences. And in fact, as a confirmation of that, you see the sort of a lung hysteresis, so the difference between, you know, going up with the pressure and then going down is visible in terms of lung aeration score only for TTM babies. And that's again another confirmation that you don't get any increment, any advantage in increasing the PEEP for RDS babies. Now, so far for all the lung ultrasound aeration score stuff. But now, why we finally decided to dive into this field is because we know that if you give surfactant earlier, like in the first 3 hours of life, you get a better efficacy. So surfactant is somehow optimized. And in fact, this is coming from a pretty old Cochrane meta-analysis. You see here, the diamond is on the left. If surfactant is given for those babies that actually need it, not as a prophylaxis, you get benefit in terms of mortality and chronic lung disease, and that means 3 hours, the first 3 hours. Now, you know better than me that when you are in the DR and then you get into the NICU, 3 hours is like a short time with all the things that you gotta do. It's you know, placing the lines and the caffeine and so on and so forth and the TPN. It's quite a short time. So either you wait for FiO2 to go up, you may be lucky, but sometimes FiO2 is going up like 6 out of life, 8 out or 4 hours, and then you have missed the optimal time window to get surfactant, or you need something to guide your surfactant administration. And based on everything I showed you, lung ultrasound may be the right tool to guide surfactant administration. Now it comes to the studies demonstrating that it was actually the right tool to guide surfactant administration. Now, that was the first study that we did in 2015, got published in JAMA with an incredible history that I'll tell you at the end of the presentation if you want. The blue curve is the ROC curve that, I don't know if you are versed in statistics, but basically the area under the curve is giving in one shot an idea of both sensitivity and specificity for a diagnostic tool like lung ultrasound. So you see here, if the lung ultrasound score was at least 8 in babies below 35 weeks, the sensitivity and specificity was very good, around 90%. When we presented that at the PAS Congress in San Diego at the time in 2015, they were like, well, okay, that's interesting, but we don't care about 34-weekers. We care about the babies below 28. So, you know, why we should be interested about that? So we went back to Paris and we did exactly the same study in babies below 28. It took us another couple of years, finally got published in 2018. And you see here, the curve is absolutely the same. The curve that you see here on the right deserves a little bit of explanation because those are curves to predict the first surfactant dose. The one on the very right is the curve to predict an eventual retreatment, so a second dose. It's not so nice like the other ones, but it's still under investigation because it's coming from very, very few babies, because in our study, we had the need for retreating like 10% of babies. It's quite rare. And we can eventually talk about the retreatment at the end of the presentation, because I know, because I got questions about that every single presentation that I'm giving, and there is a study ongoing right now. So next time I will be hopefully able to give you more insight about the retreatment. So far, yes, you can give the first dose guided by surfactant. No, you can't do that for the second dose. It's still under investigation. Besides, that's the ROC curve for the FiO2 that was into the guidelines up to a couple of years ago. So that was coming from a single retrospective, single-center Australian study that demonstrated that if you have an FiO2 above 0.3 at 1 hour of life, you get a certain sensitivity and specificity to need surfactant later on. But let's put that in a comparison. The area under the curve was 0.81, as you may see here, and in a meta-analysis that we did a few years ago, you see the area under the curve of the lung ultrasound score was 0.95, way higher than the FiO2, way higher than the chest X-rays and some, surfactant biological tools, biological tests that anyway are not used at the bedside, at least in Europe. Many other meta-analyses have been done. Here you see from Archive 2019, and then another one, and then the very last one in 2023, all say the same thing. Sensitivity and specificity is around 90%. But what is actually nice to see here is that everything is green. So that's quite high quality of all these diagnostic studies that have been done in France, in Italy, in Spain. There was in Turkey and in Canada as well. So all this was for premise, right? But what about late preterm and term babies? So that was a little bit more difficult to be studied because obviously term babies needing surfactant are not so common, right? Usually they get along with a little bit of CPAP, or well, for sure, you can be on ECMO as well, but it's more and more rare, right? So it took us to build up a network, as you may see here. There was in 2023, because I spent a year over there working at Stanford, and we finally recruited around, 200 babies, 210 babies, to finally answer the question, does the lung ultrasound score work as well for term and late preterm babies? And the answer is yes. You see the bloody rock curve is always the same, and we are more or less around 90–80% of sensitivity and specificity. And for some reason here, you see the magical number 8 is always there. So 8 is the lung ultrasound score value with both the highest sensitivity and specificity, which is important if you want to have a score used in terms of, let's say, accurate tests. Conversely, if you want to sort of a screening test, so something that will help you to say, okay, this one is not at risk to get any surfactant, so maximum sensitivity, then you got to go for a score of 4, and I'll show you later. We compared the area under the curve obtained in babies late preterm or term against those that were actually preterm, less than 32 weeks, and you see 0.88, 0.93, that's more or less the same, there's no difference, against the extremely preterm one, 0.94, no clue. The very last meta-analysis is more or less the same, and also we did some subgroup analysis, between late preterm and term, there was no difference, and between babies with ARDS or just Yali membrane disease, no difference as well. And as I said, if you look in terms of values, you get the accurate replacement test for a value of 8, and you get a triage or screening test for a value of 4, meaning that if you do your calculation, a baby with a lung ultrasound score, a term baby with a lung ultrasound score less than 4, has a post-test probability to actually get surfactant of less than 2%. 0 does not exist in medicine, but it's a pretty useful value to me. And the other way around, a term baby with respiratory distress and a lung ultrasound score more than 8 as a post-test probability of getting surfactant of more or less 50–52%, while the, let's say, baseline probability in the study was around 10–15% for that type of population. I showed you the simple lung ultrasound score, right? 6 areas, 3 per hemithorax. I'll show you later for BPD that the results are an extended one, which is very much useful for BPD, and anyway, after the first 24 hours of life. And the question was, can we use the simple one, or should we use the extended one, looking also posteriorly, like the adult ICU physicians do? That was a real American question, because for some reason in the US, it seems very complicated just to, slip the probe between the chest and the mattress, or just tilt a little bit, maybe. I don't know why, they're just joking. And so we did this multi-center study comparing the accuracy of the simple versus the extended scope, right? And quite a lot of babies, as you can see here. And those are the ROC curves. You see the black and the gray one. Nothing actually changes in the first 24 hours of life. You can use one and the other. And that's just because when it comes to the first 24 hours of life, first of all, maybe the effect of gravity is not very much evident yet. You need a little bit of time to have the lung passing from a liquid to a gas environment and have the effect of gravity installing, and so have some lung areas that are gravity dependent and some that are not gravity dependent. And the second point is that the lower the gestational age, the higher will be the incidence of RDS, right? And RDS is a homogeneous disease, as I showed you, right? So if it's homogeneous, you look posteriorly, you get exactly the same thing. However, it's also true that when you look at the term babies, you may get other diseases. You may get meconium aspiration, blood aspiration, pneumonia, other things. In these cases, it will be always prudent to have a look posteriorly to have an idea of what is happening. But as far as the surfactant administration prediction is concerned, a simple score should be more or less as accurate as the extended one. So just to show you that we actually do what we write, we decided to change our protocol on June the 1st, 2016. We call it Esther, as you can see here, just because we wanted a lady's name. And you see here, the Esther introduction is represented by the arrow. And the first 6 months of 2016 had quite a lot of late surfactant administration, represented by the red triangles. After the Esther introduction, we only had 4, and I can tell you, we continued the monitoring for many years ahead. We had no other late surfactant administration until the spring of 2020. And I remember that baby very well, because obviously it was during the first COVID wave, and it was a mess, and we were giving our ventilators to the adult ICU, and everybody was running. Well, you know the drill better than me, and so I guess that we lost this one for other reasons. And besides, the Esther policy also gave us the opportunity to reduce the oxygen exposure and maybe reduce the invasive ventilation in these babies. If you're asking yourself if the ultrasound policy is guiding better surfactant, but also pushing us to use more surfactants, the answer is no. And this is coming from my pharmacy, who was very much worried about that for financial reasons. So we analyzed the data 3 years before and 3 years after the introduction, which accounts for like thousands of babies. And you see here, the number of treatments and the number of vials actually opened is absolutely the same. And I can tell you, we use the vials by weighting the babies up to the baby's weight, meaning that if we need to open another one, we do that. And if there is a little bit of surfactant remaining in the vial, we throw it away. We're very strict. I mean, it's 200 milligrams per kilo, and we stick with that like for any other drug. We're not the only one. Some guys in Spain had the fun to do this ultra-surf trial. So this is not a before-after quality improvement design. It's a real randomized control trial. And well, the pie charts are speaking for themselves. They reduce quite significantly the incidence of late surfactant administration. But what is also interesting, if you look here in terms of SF ratio as oxygenation metrics, the ultrasound arm had a much higher SF ratio compared to the control arm after surfactant administration, which means that the surfactant efficacy was a little bit better compared to the classical FiO2 guided administration, just because obviously surfactant has been administered earlier. and so its efficacy was a little bit better than with the classical one. There's such a multi-center study now running between Spain and Italy. I'm not into this trial because for us, it was a little bit of unethical going back and randomize babies, but this trial will eventually, hopefully, tell us if this has also an impact in terms of mortality in BPD through the, let's say, greater timeliness of surfactant administration. Again, lung ultrasound is not a drug, it's not a therapy, it's a tool. You cannot get any lower mortality or BPD by doing chest film, and same for lung ultrasound, but eventually, if you optimize your therapy, maybe you can eventually do that. You can do lung ultrasound during your patient transportation. That's what we do. You see our mobile and ICU with our small ultrasound laptop over here, and the calculation is not affected by the transportation. You see, we have been doing that before, during, and after the run, I would say, and nothing changes. And also, if you look in terms of chorioamnionitis, those are data matched by propensity score, and it's like 1,200 babies with or without 1 or 0 chorioamnionitis. Nothing is actually changing. What is actually changing is when you not only have chorioamnionitis, but you have a real ARDS due to chorioamnionitis, due to the infection. So that means that the chorioamnionitis has actually involved the baby and the lung with a lot of inflammation. And in fact, you see here, babies with chorioamnionitis have a higher lung ultrasound score compared to those without ARDS. So this is our golden hour protocol. So no research, real life. It's what we do for babies below 28 weeks. Babies are coming from the liver suit, which is very close to the NICU, and on CPAP. And CPAP transmission is checked upon a NICU admission. And then the first hour is just dedicated to the line placement, UHC, caffeine bolus. We start TPN. We try not to do anything that is not actually urgent, like blood pressure measurement or IgM swab and things like that. And so, and also to obviously reduce the hypothermia risk. And so then you have 2 hours to get your lung ultrasound done, maybe even done them twice if this has been done by a resident or a house officer, as you say, to double check if you are not sure. And since the Cochrane meta-analysis says that you need to give surfactant below 3 hours of life, you have plenty of time to do your lung ultrasound, which, by the way, needs like 5-6 minutes, no more than that. So far from the first leg of my presentation, I don't know if you want to discuss that or we do the discussion at the end, so I can speak about BPD as you wish. Yeah, you guys, you're on your own. Somebody's in the kitchen, maybe. Okay, well.
I think let's carry on the discussion.
Okay.
There are currently no questions. Sorry, Jay, we couldn't hear you. There are currently no questions on the chat. I don't know if you want to give a couple of minutes or whether.
Yeah, let's go for
Sorry,
it.
Jay.
Yeah, please.
Okay, let's go for it then, and then we'll take questions at the end.
Okay. Shall I go? Can I go? Yeah.
Yeah, go for it. Thank you.
Okay. So BPD. So BPD again, we needed to be absolutely sure that what we were seeing at the lung ultrasound was an actual BPD, right? So we were forced to start with rabbits. I'm sorry. So you see those are preterm rabbit pups exposed to hyperoxia. They are known to develop an experimental BPD. They're very tiny, like 50 grams at a maximum, just like that. So those is what you actually see with the lung ultrasound. There was a good reliability between people doing that at the animal and an expert ultrasound guy like me, for example. And you can see here, rabbit and baby, that the semiology is really, really the same. The semiology is really, really the same. Those were the rabbits with the experimental BPD, and those were babies with real evolving BPD, those like stuck it on the ventilator that sometimes, unfortunately, you may have. And you see the interstitial pattern, you see the white lung, and you see obviously the consolidation. And funny enough, there was a correlation with the airway resistances. We know that BPD is an obstructive disease, right, with increased airway resistances, which impair the aeration down there in the alveoli, and this is why there's such a correlation both in rabbits and in babies. Now, we wanted to go further and be absolutely sure of obviously no histology for our babies, but indeed histology for rabbits. So you see here that that's again a correlation. Those are the rabbits with BPD. Those are the normal term control rabbits. You see a normal lung ultrasound, impaired lung ultrasound, and the alveolar radius. The alveolar radius is very much different between the two groups, and you can clearly see here the difference when it comes to the different lung ultrasound semiology. So this is just to convince you that when there is a baby with a chronic, with evolving BPD, because those were not at 36 weeks, but like 28, 21 days of gestation, the loss of lung aeration that you see is actually related to BPD, unless obviously you do the lung ultrasound during an acute event when you get late onset sepsis or necrotizing enterocolitis with white lung, which means ARDS. Well, in that case, obviously the loss of lung aeration is like sort of acute or chronic respiratory failure, and you cannot know exactly what is the part of the history that is due to BPD and what is due to something that is coming up. But otherwise, if you do that just with evolving BPD, you know that what you see is due to chronic lung disease. So what about human babies? Again, to give credit to those that did it for the first time, Almudena Alonso Ojembarrena is working in Cadiz, a beautiful city south, close to Gibraltar, by the way. And a little bit difficult to be seen with all these colors, but basically the BPD infants, they always, or almost always have the higher lung ultrasound score compared to those without BPD, 1 week, 3 weeks, 5 weeks, and so on and so forth, right? So that was the first study. And remember, the research that we just completed a few months ago about the heterogeneity gave us the possibility to go deeper and see that BPD is really heterogeneous. It's totally different compared to RDS. In fact, you see here, BPD has the highest heterogeneity in terms of intra and inter-patient. And you see here that's quite a relevant proportion of consolidation, quite a big proportion of white lung, and a little bit less of interstitial lung, with just a minority of normal lung. So that's very much important, because if you look, for example, at babies with TTN, obviously TTN is a completely different disorder, right? But TTN is also very much heterogeneous. You see here and here, but the type of heterogeneity in TTN is very different compared to BPD, because TTN is heterogeneous because they have normal lung, they have just interstitial edema, and they have a little bit of white lung with almost no consolidation. Conversely, BPD has a lot of consolidation, a lot of white lung, and interstitial edema. So those are both heterogeneous, but in a different way, and obviously BPD in a much more severe way. Now, when we talk about BPD, we talk about an heterogeneous disorder, which is already something telling us that we need to look all around. We just cannot stick with one look, anteriously. But also, we're talking about infants that are being there for like weeks or months. They absolutely have, they unavoidably have the effect of gravity, like the adult guys in the ICU. In fact, you see this is coming again from an adult ICU in France, and you see the difference in aeration between the non-dependent, the middle, and the dependent areas for a guy that is lying supine at the chest scan. Okay, again, we don't do chest scan in babies, but that's the same for us. And on top of that, we know that infants are flicked quite often by nurses, and that can have an impact, and we're gonna describe that in a minute. So to have a more comprehensive understanding of what is happening there, we needed another score. We needed a score that was actually looking also posteriorly. Obviously, semiology is always the same. This is not gonna change. It's 0 to 3, 4 signs, We're not inventing anything over here, but we decided to look at the upper posterior, which is corresponding to the upper anterior zone, and the lower posterior, which is corresponding to the lower anterior zone. So basically, rather than 6 areas, now you have 10, and the score is not going from 0 to 18, but it's going from 0 to 30. And again, no need to swift the baby, just tilt a little bit or just slip the probe between the mattress and the chest. It's very easy. Now, that score has been used to study, for example, pronation. There's Barbara, my fellow, who did that and got published a couple of years ago. Again, another big study. And you see here in blue or violet, according to the color, you get the babies going from supine to prone position. And on green, you get the opposite, right? For example, here, you see, this one was supine and now is prone, and the lung ultrasound aberration score is going down significantly, right? So there is an increment, a net recruitment, a net increment of aeration by pronation. If you look, for example, at the FiO2 here, sorry, the PF ratio here, or the oxygenation index here, or the CO2, all the gas exchange is improving with the pronation. Those have been done after 6 hours of pronation, right? And that is interesting because apparently in the adult ICU, they get the same only after 12, if not 18 hours. We see a difference only after 6 hours. But interesting enough, when you do the opposite, you see here, you go from prone positioning to supine positioning. What you earned is being lost in terms of aeration and in terms of PF ratio and gas exchange. So that's important. There is an efficacy of pronation, but you also lose the effect. And what is also interesting is that we did that in every type of baby, but those that are experiencing the highest, the greatest benefit are the BPD ones. And the BPD ones, maybe just because they are the more heterogeneous ones, and obviously the sickest ones anyway. So this is why, on a practical point of view, and also for some suggestion for research for the future, when we have a baby that is stuck in on the ventilator with BPD and so on and so forth, we tend to have them always on prone positioning as much as possible to reduce the oxygen exposure, obviously. Now, this is what you see. I'm sorry, the definition is not so good, but the consolidation that were here on the supine position are really shifted with the prone positioning. And coming back to the extended lung ultrasound score, we did the study like our Spanish friends, and you see 0, 7, 14, 28, and 36 weeks. You see, the BPD babies always have a higher lung ultrasound score compared to those without BPD. And again, the famous or infamous lung ultrasound, the ROC curve, tell us that there is a very good predictivity when you use the lung ultrasound extended aeration score at 7 or 14 days to predict BPD at 36 weeks. And that's important for us to talk with parents, but it's also important in terms of research development, as I'll show you in a minute. There was a multi-center study that we did between Italy and France. It got published in 21, but then many other studies have been done with exactly the same design. And you see there was from Canada, China, Spain, Italy again. I guess this was somewhere in the US, I don't remember. And again, if you put them all together, the message is always the same. You get more or less 80–85% of both sensitivity and specificity to predict BPD at 7, a little bit better at 14 days of life. So I do suggest you to do that at 14 days. And the thresholds to be used are these ones. So if you use a simple lung ultrasound score, which is so between 5 and 7, and for an extended, it's between 11, 10, 12, more or less. Interestingly enough, you can ask yourself what is going to happen to the aeration score if you look at infants with BPD on a long-term basis, right? And these guys close to Venice in northern Italy, they did that, and you see up to 8 months of follow-up. It's interesting to see that infants with BPD, they have a higher score for sure, but the score is going down, so the baby is improving, right? However, if you take those with severe BPD, that hopefully are not so many, so those, with oxygen at home, unfortunately, they stay with a much higher lung ultrasound score, even at 4 months and at 8 months. So that tells something to us. First of all, you can use that on a follow-up basis, but also it gives you an information about how things are going also out of the acute setting, also out of the ICU. And in fact, we participated in this other multi-center study together again with these friends from Venice, and you see there's a lot of correlation here, a lot of numbers, but to be very practical, there's a correlation, there's a predictivity of the lung ultrasonation score at 7 and 14 days, even in terms of need for respiratory drugs during the follow-up, or need for respiratory hospitalization later on, which means, again, those with severe BPD, not only those, because sometimes you can get re-hospitalized for RSV, bronchiolitis and so on. That has been done before the era of RSV immunization, so a few years ago, but it took quite a lot to get published actually, but it was before the Semivab or whatever you call it. Now, what about the future? And what about research implications, as Jay said? We need to see things in perspective. Some years ago, the International Neonatal Consortium said in 2017 that BPD is just a piece of the cake, of a much, much bigger cake that is called CPIP, chronic pulmonary insufficiency of prematurity, that is starting there, but eventually is lasting for like 1 year, 2 years. In fact, FDA, but I guess also the EMA, are much more interested in having like the respiratory function of 1 year as an outcome rather than just BPD, because many BPD babies, then they're just doing fine. You saw lung score is going down as not a very big deal. But when you look in terms of respiratory function 1 year and 2 years, and there are scores to describe the respiratory function at that time point, then you can eventually use the lung ultrasound score over here, like around 14 days, very early, to predict those babies that are having not only BPD, but more severe BPD, and eventually more severe respiratory derangement later on. And that could be, to me, maybe I'm a little bit visionary, but who knows, used to guide some experimental therapies that are now under advanced clinical investigation. I don't know if you guys are into the IGF-1 footprint trial. Some are in the UK, will be starting in France, I guess very soon. But there is also the phase 3 randomized controlled trial about the human recombinant surfactant protein D to be given right after surfactant. We are in this trial right now in Paris, and that's just the phase 3 trial for BPD, because there are others that hopefully, who knows, will come there, and they are actually now under phase 1 or 2 or preclinical investigation, notably the vesicle, stem cells, and I remember the oral vitamin A. That was a British trial on oral vitamin A. I don't know if you know more or less where we stand with this one. I lost contact, but I know that there was this trial running. And conversely, regarding the, let's say, titration of the respiratory support, well, lung ultrasonation score is already useful at the bedside and is used by my team every day to somehow titrate and personalize the respiratory assistance, because if you have, in these babies with BPD, a higher need for oxygen, you know that possibly that's an increment in the airway resistances, you know that now that's the derangement of the alveolarization, you want to check how much aeration there is with the lung ultrasound and eventually increase the PEEP or the mean airway pressure, whatever, to open up the lungs and eventually reduce the oxygen exposure, which is toxic for many, many things. This is what we do. Basically, those babies are on CPAP more or less biphasic or single level until they get they do not go well, otherwise they stay in CPAP. But if they are very sick, depending on what we see, if there is only an oxygen impairment, oxygenation impairment, usually we go to NEVA. We use a lot of NAVA and they're just doing fine, but we titrate that with lung ultrasound. Otherwise, if we find somebody with a real respiratory acidosis, we have been using even nasal air frequency to get rid of the carbon dioxide and eventually get back to NAVA. I want to be very, very honest with you. We use less of nasal air frequency right now because we use a lot of NAVA, and most of the time they're just doing fine. But sometimes we use also NAVA. We also the nasal air frequency as a rescue when NAVA is not working. And all this, as you can see here, is monitored with the lung ultrasound and in a very mini-invasive fashion, just looking at the saturation, maybe transcutaneous oxygenation, adding and comfort score by our nurses. We tend to do as less as possible blood gases, sometimes obviously the capillary ones and so on. But lung ultrasound has actually a crucial role in the management of this, and I can tell you that if you come to the NICU right now, you look at these babies, 90% of them are not intubated. It's sometimes you get somebody stuck on the ventilator, but it's very, very rare. We do as much as we can to stay away from the ETT anyway. And as I said, we use the lung ultrasound to titrate the mechanical, well, the respiratory support, which means to do the alveolar recruitment anyway. And as you can see here, we reason in terms of PV curve. So when you are at very low pressure level, it doesn't matter if it's a PEEP or a mean wave pressure in high frequency oscillation, doesn't matter. You obviously get this, a closed lung, you start to increase the pressure, and at a given point in time, the lung is opening up, right? And then you start to see here the white lung and the low inflection point, and then you increase again the pressure here, and you get a pretty nice increment in volume, and you see hopefully you see the normal A lines, meaning that you have just opened up the lung, right? We do that in a stepwise fashion, you see here, like that, placing the probe on the worst lung area that we see, like the worst consolidation that we have found, and we titrate according to that, obviously coupled with a little bit of a functional echocardiography that we do in the beginning. You see here check hemodynamics just to be sure that, you know, volume filling is fine, a little bit of contractility is fine, the basic things. And then just to conclude, be careful, because now I told you everything has been done so far with this microlinear high frequency probe of more or less 18 megahertz, but now beautiful, even smaller probes have been made available. They're just like my nail, very, very small, and they can go beyond 20 megahertz. And that's Victor, my fellow, who did this study. And you can clearly see, I mean, the picture is speaking for itself. The higher the frequency, the more the B lines you can see. That means that if a lung is normal and it's only A lines, there's no problem. If you get a consolidation, there's no problem neither. But if you are in the middle, in terms of B lines, you can see more, and so the score calculation can be affected. And all the literature has been done so far with a frequency that was anyway lower than 20. So if you use the ultra high frequency probes, you gotta take this into account. I'm not telling you that this is bad. It's not bad. It's just it's small, and we just need to adjust to this new tool.
Reset the score.
Yeah, exactly. If you're interested, the European Society for Pediatric and Neonatal Intensive Care did this guidelines back in 2020. This is open access, so it's freely downloadable. Now we are in the process of updating it. Not very much big news about that. But the very big news is that both the ESPNIC and the ESICM, which is the Society of Adult Intensivists that are using lung ultrasound for quite a lot of time, much more than us, together we decided to do a joint consensus of quantitative lung ultrasound. This is going to be published in the first quarter, hopefully, and we'll be telling you more or less what I told you, but with many, many other details, so hopefully we'll do another thing for that very soon. Okay, so thank you, and happy to take your questions.
Let's see whether we can.
Thank you very much. We have two questions online. Are you happy for me to go ahead with the online questions?
Yeah, go for it.
Yeah, it's a two-part question. One question which has two parts to it. So I'll give you the first part. It's from Dr. Anna Milan. So the first part is about near-term babies and their need for surfactant. How has your practice changed with a post-test probability of only 50%?
If I get it correctly, you're asking me how the probability has changed, or what?
No, how your practice has changed.
My practices. Well, I want to be honest with you. While for preterm babies we dramatically change it. I mean, we don't follow the FiO2 anymore. For late preterm and term babies, we are a little bit more. I don't want to say cautious, but I would say more comprehensive. I'll tell you why. Well, first of all, ours was the first study about that, but it was a very nice one, multi-center, big sample size, and so on and so forth. But the real reason why we didn't change suddenly, like we did for premise, is that when you do earlier optimized surfactant administration for premise, you get less mortality and less BPD. But when it comes to term babies, you don't get BPD anyway, first of all, and mortality is much more complex issue, right? So, okay, giving earlier surfactant is always good, but you're not very, very much worried about these babies. And this is also why we stressed quite a lot this history of the triage or screening test, because in my opinion, that could be the real novelty when it comes to the outborn babies. I don't know you guys here, but we are the referral center for like 22,000 deliveries. And most of the time, these babies are not coming from my delivery room. They are coming from some first level 1, level 2 centers. They call you and they say, it's doing bad and so on and so forth. And if you can actually do the lung ultrasound score there, you can decide and tell them, okay, bring them over, or we're going to come to retrieve him, or you can tell them, no way, this is going to be fine. That's the real novelty. Now, to be very practical, when a baby of this type comes to my NICU right now, he or she obviously gets the lung ultrasound, and we take that into account together with all the rest. But we don't give surfactant exclusively on the lung ultrasound score. Although, if you want, it's a little bit yin and yang, because if you get a very high lung ultrasound score, the baby will need oxygen anyway. So, but we take this into consideration anyway. I don't know if I answered the question.
I think that was very clear. Yes, thank you very much. The second part of this question, and then I'll open the question to the panelists and then go back to the chat again. So in these patients, do you envision the possibility of developing a combined score to include lung ultrasound with other measurements?
Yeah, why not? I mean, you can do whatever you want. I know that there is a team in southern Italy that already did that, combining lung ultrasound ratio score with the SF ratio, the saturation over FiO2 ratio. They even published a calculator, which is online. And it seems that combining the SF ratio with the lung ultrasound score would be even more accurate to predict surfactant need in preterm babies. I'm a little bit, let's say, philosophical about that, and I'll tell you why. Because anyway, even in these babies, in these particular studies about the SF ratio, the target, which is the need for surfactant, was defined by an FiO2 threshold, because that's what everybody was used to use, right? Now, the fact that a metric including FiO2, like the SF ratio, would be very accurate to predict an FiO2 target, to me, it's obvious, and so that's a particular bias that is called prediction bias. So this is why I'm not actually sure that combining SF ratio with lung ultrasound would be anyhow more accurate, but there are people working on that.
Thank you. I don't know, Jay, if you want to open up to the room.
Yes, yeah. Any other questions around? If we are waiting for it, let's ask a few more questions maybe.
There are some, yeah.
There are questions online, but it's just opening it up to people who are face-to-face and to the panelists if you have anything before we continue with online.
Yes.
Sticking with the late term lung ultrasound score, the surfactant administration prediction value you said of 52% was based on
post-test probability.
Post-test probability was based on a lung ultrasound score of 8.
Yeah.
I wonder if that has been done for higher scores and whether the predictability was higher.
Probably this is going to change. Probably this is going to change according to the threshold that you choose. That's pure mathematics. But the problem is that if that was associated with 8, because it gets the highest sensitivity and the highest specificity at the same time. If you change, you're going to get either one or the other. It depends on what you want. Yeah.
So a question about the BPD and predictability based on lung ultrasound score. So you said that between 7 and 14 days, you can predict severe BPD and things like that. So based on that, do you target any specific interventions? And have you observed any changes in the BPD rates from that?
Obviously, so far, we do not have any particular intervention for BPD, unfortunately, out of the trials that I mentioned. But what we do when we have such a high score of 14 days is that, as I said, we titrate the ventilation, and not only 14 days, because we did it almost every day in order to optimize the therapy, and not only having a good compensation in terms of gas exchange, but also trying to reduce the oxygen exposure as much as possible for both reasons. We use vitamin A, intramuscular vitamin A, but this has been started well before, as you know. And unfortunately, we start to talk with the families, explaining them that there may be quite a high likelihood to have a chronic lung disease later on.
Yeah, just attaching to that same question. So can you actually predict someone going home on home oxygen?
Yeah.
Looking at the day 7 and day 14 scores.
Particularly on day 14, you get I would say, a lung ultrasound score extended of, more than 12, more than 15, let's say 15. That is going to be quite bad. Then obviously, stick to the BPD definition, because the need to have oxygen is also depending, on some logistics and how things are done on the network and so on. That could be a little bit different, But anyway, severe BPD, yes.
Can I just add a comment here? So first, thank you, Professor De Luca, for this excellent presentation. Really lovely to have you here with us. Just a few comments about the previous question, and I wonder if you can just comment on that as well, please. Regarding the late preterm infants who present with respiratory distress and, query RDS on probably unequivocal X-ray, etc. And I know there was a recently published paper saying if the lung score is 9 or more, that would recommend surfactant. But as you know, we all know, those late preterm babies, usually it's not simple. It's not pure RDS. If they have, usually there is overlapping, poor transition, an element of pulmonary hypertension, and only lung ultrasound doesn't give you the full answer about that. So I just want to let people use it cautiously, as you said already, because it's not purely RDS. And sometimes those babies would benefit from just time rather than just surfactant, and possibly, intervention for pulmonary hypertension. So I suppose maybe combining lung ultrasound with echo, if possible, that will give you more accurate answer. If you're not quite sure if the diagnosis is not fitting the clinical picture of RDS, unless there is obviously background history of, 35-weeker, infant of diabetic mother, no antenatal steroid, etc., more likely to be RDS, which is okay. But sometimes if you're not quite sure with the score of lung ultrasound, possibly just get more diagnostic measure, if that makes sense? What do you think?
Okay, let me get this straight. As I said, the lung ultrasound should be integrated with all the other information. That's very much important for any patient and also for the late preterm and term ones. What we do is that for every single baby that is getting into the NICU, every time we do a point of care echocardiography and a lung ultrasound at the same time. And we separate very much what is of vascular origin and what is of parenchymal origin. Now, obviously, if there is evidence of PPHN, if there is evidence of the echocardiography of a right-left shunt, that means that they can contribute to the hypoxia, and that should be taken into account, for sure. So I do recommend to do point of care echocardiography at the same time for these babies, absolutely. However, even if you have this, and you find that the lung is not perfectly aerated, well, that means that on top of the vascular origin of the hypoxia, you also have a lung problem, for sure, 100%. Now, what type of lung problem do we have? That's a second question, that's a further question, because as you said, you can have RDS, you can have TTN, you can have ARDS, and here comes the qualitative evaluation of the lung ultrasound, which is not only the score calculation. And when you look qualitatively at the lung ultrasound findings, you can distinguish, and you can say, this is RDS, homogeneous, white lung, and so on. This is more of a TTN in terms of lung parenchyma, or this is supposedly an ARDS, for which you also have to take into account all the other criteria to diagnose the ARDS, and so all the clinical history. You gotta have a trigger for ARDS, and so on and so forth. So this is what we put all together, which is a little bit what you said, but I would suggest also to go out of the, let's say, classical, classifications. And I love very much to reason in terms of what is coming from the vascular side and what is coming from the parenchymal side. Let's make some examples. Let's say that we have a baby who is very much heterogeneous, but with a lot of A lines. So qualitatively, it looks like a TTN, and it also has a little bit of right to left shunt, or maybe not. That's probably a baby for whom we wouldn't give any surfactant. But by doing all this ultrasound, we have understood his or her physiology much better. Conversely, let's imagine a baby who's very much homogeneous, with a wide lung, okay, everywhere or almost everywhere. Doesn't matter if he has PPHN or not, a lung like that with oxygen need, you would treat him and give surfactant. Or the other way around, a baby with an history of maybe meconium-stained amniotic fluid, you never know, it's coming from another hospital, something like that. Some lung ultrasound findings very much patchy, irregular, and so on. That looks like a meconium-induced aspiration, ARDS, something like that. You may want to give anyway surfactant before nitric oxide, something like that. So it's very much important to put everything together and have a pathophysiological reason to me. And that's why we do not go straight forward for surfactant for every single baby of this type.
Perfect, thank you.
You wanted to ask a question? Okay. Can I ask
Sure.
a technical question?
Yeah.
So baby with BPD or evolving BPD. So obviously we look at the lung ultrasound scores on day 7 or day 14. But these babies may also have PDA. So they will have probably more B lines as well because of the lung being flooded. So how can you distinguish between the two?
You can't. You just can't. That's the eternal question that has been raised up even in the adult ICU when they ask, for example, if you can distinguish between cardiogenic pulmonary edema and the real ARDS. Let's face the fact. Lung ultrasound is telling you that the air fluid ratio in the alveoli is reduced, okay? But then, if the fluid it's coming from the PDA because of a left to right shunt, or from the heart in a grandma with cardiogenic pulmonary edema, or it's coming from the inflammation related to BPD. You cannot know. I mean, this lung ultrasound cannot tell you that. Again, you need to integrate with the clinical history. Maybe you want to have a look. With time to time, we measure the pro-BNP, you know, this type of indexes, and there are also others coming up. And then you need to understand if the PDA is hemodynamically significant with all this beautiful measurement that we all do. That's what you can do.
Yeah.
Jay.
Sorry.
So there are quite a few questions on the chat. Sorry to interrupt. There are quite a few questions on the.
That's a lot of questions here. Yeah.
Asha, if you can read the questions, if you don't mind.
Okay. I think the next question is from Ben. I've done research on the method of surfactant administration and its impact on lung ultrasound. For example, Insure versus Lisa.
Right. Okay. Well, first of all, everybody knows that I'm against Lisa. I'm a very big Lisa enemy. I'm sure you have read all my papers in Lancet and with Eduardo for many reasons that I'm not going to cover today. But that's for another webinar. But the short answer is yes. There are some data showing that when you do Insure and you do the lung ultrasound after a little bit from Insure, surfactant is better distributed and the lung is more aerated compared to Lisa, where conversely the lung ultrasound score remains a little bit higher. That's not surprising because you do not apply any pressure, and unavoidably you need pressure to distribute surfactant. To be honest with you, it's also consistent with animal study that has been published in 2014 by Dutch guys in pediatric research showing, heterogeneity of lung aeration after Lisa treatment, and with other data that have not been published and will never be published for political reasons. I don't know if I can say so.
Thank you. We'll go to the next question. Next one is from Justinas. It's an interesting question. If RDS is homogeneous disease, should the score used to diagnose it to be 12, that is 2 in each region assessed? A score of 8 means some areas will be scored as 1,
Sure.
which would be against the definition of RDS.
You are totally right, but we need to remember 2 things. First of all, even in the study that I showed you, we published it in Journal of Pediatrics 2018, if I can recall correctly, the average score of RDS was 11, with a little bit of standard deviation, Now, that means that in medicine and in life, it's never black or white, right? We have different shades of gray, like the book or the movie, if you want. And we need to take that into account because the nature is a continuum. And obviously, you can use 10 or 12. That's absolutely no problem with that. But again, if you do that, you are going to pay a price in terms of sensitivity and specificity, like any other diagnostic tests. I can, let's say, turn it around and tell you that to get the diagnosis of hepatitis, you need, I don't know, ALT above X, but this does not mean that you don't get hepatitis if you are at X minus something. You may get it anyway. So that's the point.
Thank you. We'll go to the next question. That is from Ajay Sinha. He says, fantastic talk, Prof. Luca. The question is, the scans are clearly operator dependent. How do you train your juniors to achieve proficiency in performing and interpreting the scan? I may have missed it, but do you have any data on inter-observer agreement?
Yes, my friend, you did. You missed it, but I didn't show all the data, and those are not only from my group, but there are countless in the literature from adults, from neonates, and so on. And I have to tell you that once upon a time, no, lung ultrasound is not operator dependent. That's a concept really from the past. That's a huge amount of data showing that the correlation coefficient, the interoperator agreement, whatever you may call it, is extremely high for recognizing the 4 basic semiology signs, so A lines, B lines, white line, and consolidation. The ICC is way higher than 0.9 in any type of study. I just remember mine, but again, there are many, many others that have been published in CHEST in 2020. That was particularly interesting, not just because it was mine, but because we also, let's say, merged not only different types of probes to study the interoperator agreement, but different types of operator, right? And as I told you, the linear probe is the best one, but even if you do the score, or anyway, the lung ultrasound with like microconvex or phased array, you get the same interoperator agreement unless you give a nonlinear probe in a very, very young resident hands, like the one that just came into the hospital. Well, in that case, your interoperator agreement is going down significantly. So that's the bad combination that you don't want to have. Otherwise, no, it's not operator dependent.
Thank you. Next is the last question online.
Oh, by the way, he asked something about the how much training do we need?
Yes, training. Yeah.
Well, that's important. There is a formal learning curve described in the adult ICU. There are beautiful papers in the Blue Journal and Anesthesiology done by many people, particularly by a French girl, Charlotte Arbol. Oh my goodness, Arbolet. Well, something like that. I can send you the paper if you want. Well, anyway, in the adult ICU, they need 25 scans. And on 25 scans, they get 80% of agreement with the senior ultrasonographer. Now, we're doing that. We're doing the same type of study. It's not finished yet, but the impression I can give you is that, at least with my residents that are coming into the NICU, after 6 months, they are totally proficient. After 1 month, 1.5 months, they are perfectly fine to distinguish RDS from TTN and so forth.
Thank you. The next question is from Jean Young. Fantastic talk, inspiring research and excellent talk. Thank you. Do you have a standardized training package or standardized settings for lung ultrasound with your work across international site and multicentric research studies?
I can only tell you how do we do things. We have a very much formalized course that is a 1-day course. And we've been training like thousands of people this way. We can do also something for you or with you, even coming year, basically, that would be very fun. After the course, you need 2 weeks of scans every day. You'll be totally proficient. That's what we have been getting the impression all around the world. We even work with somebody from Yerevan in Armenia, which is supposed to be like sort of a developing countries again. These guys, they did the same, and then they went back to Yerevan. And for like 2 weeks, they were sending the images. And so I could evaluate the images in a sort of a telemedicine and so on. And after a couple of weeks, they were just fine. So that's what I can tell you. It's not the only way to do things. There are, I guess, numerous courses, endless courses all around the world. There are some online, some whatever. So I cannot tell you that mine is best or 2 weeks is best, that it's better than 3 or something. But I guess more or less it's this type of things.
Yeah, thanks.
It's actually much more easier than hemodynamic assessment.
Oh, you bet.
Yeah.
You bet. Absolutely. It's much, much easier than echocardiography.
Is there any number of scans they have to do in 2 weeks period? Like, is it 14 scan or 20 scans? Anything you particularly suggest?
As I said, in adults it's 25. Okay. I'm not able to give you a number for neonates. Hopefully I will be able to give you a number very soon as we finish the study on this. We have been going slowly because we needed residents that were absolutely virgin in terms of lung ultrasound. So this is why we need some rabid residents to do the study. So and besides, you wanna, I can tell you, when we sent this study to the IRB, I mean, to me it was straightforward. I mean, we're not even using babies, we're using residents, right? that was the worst IRB ever. They were scared about the stress of residents. They were scared about, like, they were feeling under examination for the lung ultrasound. They're feeling like that for the whole rotation, you know. Just well, finally got approved, but it was a little bit tough.
You never know what ethics is going to ask you.
Last question, again from Jin Yong. Do you use lung ultrasound in RDS to wean respiratory support?
It depends what you mean. If you mean just really for RDS ventilatory support, for me means inshore. That's what we do, right? And we have an average of 7 minutes of ventilation. So in 7 minutes, you're not going to get again another lung ultrasound. And anyway, it would be useless because you just injected surfactant. So you only see the water all around. It's useless. If we're talking about, conversely, somebody that is on the ventilator for more than an inshore, because he has ARDS or for some other reason, yes, we use the lung ultrasound, but again, in an integrated way. So we do not extubate only based on that. We look at the patient in a more comprehensive way, although I can tell you that there are data published demonstrating some accuracy of lung ultrasound to decide about the extubation. But again, we prefer to have a more comprehensive way because, let's face it, lung ultrasound will tell you if the lung disease is resolved, and you want to have this to extubate the baby. But if the baby has a lot of apneas because sedation is too high or because apnea prematurities, lung ultrasound is not telling you anything about that. Or if hemodynamics is poor, despite the lung has been, let's say, is no more insured, you're going to get an extubation failure. So you have the need to look at the hemodynamics again. So you need to see all these things to decide in a more careful way.
Thank you. Yeah, that's the last question on online.
Do you use lung ultrasound for starting or cutting diuretics? Yes and no. The answer is yes and no, meaning that, first of all, we rarely use diuretics. We try to use as less as possible for those reasons. But when we have, let's say, the suspicion of lung edema, we take lung ultrasound findings into consideration to start the diuretics and eventually to stop it, for sure.
That's absolutely fascinating talk and discussion. Sorry, Sadaf, you have any other question?
No, I was just going to say thank you so much because I think we're getting to time. But I'll let you finish, Jay, and then we'll close at the end.
No, I'm just saying that it's a great honor to have someone speaking for almost 1.5 hours. 2 minutes short of 1.5 hours.
It's a pleasure.
I'm sure he can talk for 12 hours.
I told you during the presentation that there are other things that are not for the talk of today. So that's just another option for the future, as soon as I come back to London.
Sadaf, yeah.
I'm sure we can probably listen for more than 1.5 hours. We'll probably be happy to listen for hours and hours. It was really interesting. Thank you so much.
But you will need a coffee, and I will need a coffee as well.
Thank you so much for coming to talk to us at NeoFOCUS, and thank you to all the participants. Hopefully, we've just set this up this week, but you should be able to get certificates tomorrow sent to you by email.
Great.
Thank
Thank
you,
Professor. Thank you very much. Thank you. Excellent talk. Thank you.
Thank you, guys.
Thank you.
Beautiful.